I've been asked to talk about professionalisation of the surgical trainer. I work in the TED work stream, which is the Trainer Education Development work stream, which is essentially faculty development for the IST project. And right from the start, this concept of professionalisation of the trainer has been a key tenet of the IST project. And it's one that we're very keen to progress. So what do we mean by that? What do we want? Well, obviously, the focus in this entire project is improving surgical training for the benefit of our trainees and ultimately the benefit of our patients. But I think we have to be very cognizant of the fact that we also want to improve life for our trainers as well. Certainly looking at the latest GMC survey, the trainers are not the most satisfied lot at the moment either, and we would hope that this is a lever to try and improve that. So what do we want as the goals for a trainer as part of the IST project? And well, you can see them outlined here. So we do want to see an increased value placed on training, and I hope the IST project as a whole will do that. And as I said, we want to use this to increase this professionalisation of the trainer role, so that it's not something that's just seen as something that you can do in your spare time when you've got a few, 5 minutes to spare in your busy schedule. Can you do some training? I think we've got to move away from that. So we've got to be able to recognise and reward excellence as a trainer, so that trainers feel valued and increase our trainer satisfaction, because we've got a more satisfied bunch of trainers, we will have better training and a more satisfied tranche of trainees. And we know that trainers do a fantastic job within very limited resource environments at the moment, but we also know from multiple sources that there is room for improvement. These are some of the drivers that we have been thinking about as a TED faculty development group that we know need some tweaking, some improvement. Feedback delivery, we know that feedback is absolutely essential to all forms of education, medical education and surgical education. And we know it's not done that well. Certainly if you ask our trainees how often they get effective feedback, literature suggests about 16% of them say they receive effective feedback all the time, whereas if you ask the trainers, about 70 to 80% think they give feedback. So there's a disconnect there that we need to sort out. And we do need to move towards a more modern delivery of feedback. So we want to encourage feedback to be dialogic, a dialogue between the trainer and the trainee rather than a transmit or receive process. There has to be a two-way street there. We want feedback to be performance enhancing. We need to move away from the bad dog school of feedback, which I think sometimes we are all guilty of. And when I talk feedback, I'm talking in the widest possible sense, both verbal feedback given during training, but also written feedback, as in recorded in ISCP, as used in supervisor reports. All this is written feedback, and I think we need to improve on that. Assessment is also something we're used to doing. Assessment is often coupled with the word burden, which I worry about. I don't think if you're a trainer, assessment should not be seen as a burden. I think if you're a trainer talking about the burden of assessment, it's a bit like being a surgeon and talking about the burden of closing the wound at the end of the operation. I think if you're a trainer, it's part and parcel of your job as a trainer. But we want to move again away from this very tick box exercise that I think some assessments have become. We want to be able to rely very much on your professional judgment as a trainer, but capture that judgment accurately and allow you to articulate that judgment more clearly, both for the trainee, and when you're recording those assessment decisions throughout the year to chart progress, and also as it's feeding into the RCP process. And I'm sure we've probably mentioned the GMC Excellence by Design document, and that is very clear that as an assessor, you are now going to have to be benchmarked, which is not something that we're used to. And I think that is a very useful exercise that we want to build in, is benchmarking what good assessment is, what bad assessment is. you need to be able to reliably distinguish between different levels of performance, is what the GMC say. And we're working on benchmarking processes to allow you to do that. And that feeds into better progress assessment. Reduce what we call criterion uncertainty. So give you very, very clear waypoints that you can recognise and measure your trainee against, so you know exactly where they should be at a particular point in time. You can benchmark your trainee against that standard and use performance-enhancing feedback to move them in that direction. And also to recognise excellence when your trainee is above that threshold and how you can encourage that. And ultimately we want that to lead to reduced failure to fail decisions. Unfortunately, we're probably all too familiar with the penultimate year trainee who comes through to the ARCP process and someone raises concerns about awarding this person a CCT. But you look back at all the ARCP assessments and no one's raised a concern before. And I do think GPCs, the generic professional capabilities, will give us a new language and framework with which to do that. And that again feeds into better reporting. Improved written reports, clinical supervisor reports, and AES reports, as will be used in the IST pilot, but probably moving on to multi-consultant reporting. So instead of these reports happening completely in isolation, we would like to see consultant trainers looking after one trainee coming together and actually discussing that trainee's progress and producing almost a consolidated report, which again will feed into an improved ARCP process, which is obviously part of a separate work stream. And I think one of my jobs here today, and we'll explore this more in the breakout sessions later on, is to reassure you that there are no new tools within the IST project. We will be using the same workplace-based assessments. We've still got the hatchet of the PBA, the hammer of the KEX, things you're all familiar with. So there are no new tools to get to grips with. We just want to give you the ability to use them very effectively. As I said, that's within the IST pilot, but we're not designing this faculty development initiative in isolation. As I've already mentioned, excellence by design, and that is going to require a move towards these high-level outcomes. Strictly not within the IST pilot, but in the certainly within the second year of the IST pilot, if you've got an exceptional trainee, you probably are going to want to draw down on some of these high-level outcomes that are the SIPs, the capabilities in practice that we've been talking about. But as I said, the other important thing for us to bear in mind is that the GMC are very clear on this benchmarking of trainers, which is not something that we have done. Recognition of trainers doesn't go that far, so we need to put that in place. And again, although not strictly part of the IST pilot, that benchmarking process is very useful for you as a trainer, just to see how, to gauge your trainees' progress, recognise excellence, recognise when trainees need additional support. As I said, we have discussed generic professional capabilities. These are going to be universal throughout all curricula. And I do think they give us a valuable framework and a language in articulating our trainees' progress. Certainly we know that most of the trainees who are not meeting our expectations, it's not usually the technical skills, it is the non-technical skills that they struggle with. And sometimes part of our issue is articulating that clearly, and I think this does give us a very granular language that we can use to articulate and remediate these trainees and also to recognise excellence, as I said before. We've talked about capabilities in practice, these high-level outcomes for our trainees, and because of that, we have invented, if you like, a TSIP or a trainer SIP, a capability in practice for a trainer. We think it shows constructive alignment, but one of the things that we've always been asked is the trainers want, what is expected of us as trainers in this IST pilot. And a capability in practice for your trainee very clearly sets out what you expect of your trainee. So we think it's proper that as a trainer, you also have exactly what is expected of you set out very clearly. And like a SIP, which is a version of an entrustable professional activity, it's divided into 3 areas, which very clearly lays out what the activities we think you should be doing as a trainer, what are the knowledge and skills that you require to carry out those activities, and what are the required behaviours that you need to be an effective trainer. And just some examples. Again, I hope this is reassuring that the activities, and again, this is not an exhaustive list, this is just a few examples we've picked out, are things that trainers do. We're not bringing up anything new. So it's things like ensuring induction, co-constructing a learning agreement. What we just hope to set out is a very clear method for you to do this effectively. And likewise, the required knowledge and skills to carry out those activities, I don't think you'll find them, they're not at all controversial. Using feedback to enhance performance, reviewing and benchmarking your trainees' progress. But clearly set out as a set of expectations of what you should be doing as a trainer. And the behaviours that we set out are essentially mapped to the standards for surgical trainers that were set out by the Faculty of Surgical Trainers. One of the reasons we've done this is this document is already out there, and also it will be mapped into ISCP in the very near future, so there will already be an evidence gathering tool for you as a trainer to record these behaviours. But what's this going to look like practically? As I said, the trainer capabilities in practice very clearly sets out what we expect a trainer to be doing within the IST pilot. There will be online resources, and there will also be face-to-face teaching in June, July 2018 for assigned educational supervisors within the pilot. We will be looking at assessment benchmarking. That will be a combination of face-to-face and online teaching. It will focus on the mandatory core workplace-based assessments as an example. And you will run different scenarios looking at levels of performance, but also starting to bring in entrustment concepts, which is a new thing. And that's, again, not within the IST pilot, but it is something we're all going to have to get used to. So we're going to start introducing how to make entrustment decisions. Now again, entrustment decisions is something we do all the time. When you decide you're going to leave your trainee to run that clinic or run that operating list, but we perhaps don't do it as consciously as we think. So this just gives you the ability to consciously make that decision and also articulate how you've come to that entrustment decision. We'll be using that material to introduce generic professional capabilities and also looking at reducing unconscious bias, rater cognition, rater variability, trying to benchmark everyone to the same level. We'll be giving you resources, again, mainly face-to-face for this, on how to produce performance-enhancing feedback, and also on how to produce written reports, including learning agreements, including clinical supervisor reports and educational supervisor reports, using written exemplars and workshops to actually produce these. And I'm running out of time, so I'm going to leave it there. Are we allowed questions just now, or not yet? No, Sam says no.